For decades, women have been handed a specific set of rules to prevent their breasts from sagging. We are told to avoid going braless, and we are warned that breastfeeding will inevitably ruin our shape. The problem is, medical data doesn't support either claim. You can see the misunderstanding of breast anatomy in this vintage photograph of women doing group chest exercises. The prevailing advice was that toning your chest would lift your bust, but pectoral muscles lie completely beneath the mammary glands. Exercising that muscle base cannot tighten the soft tissue resting on top of it. The drivers of tissue degradation are tied to skin elasticity. Advancing age and drastic weight fluctuations stretch the skin over time. Lifestyle factors play a role as well. Smoking, for instance, restricts blood flow and destroys the collagen needed to keep skin firm. While breastfeeding itself isn't a culprit, the broader biological process of pregnancy is. During gestation, hormones soften the connective tissue to prepare for milk production, while the sheer physical mass of the breast undergoes a rapid, cyclical expansion. To understand why that expansion is destructive, we have to look at this 3D cross-sectional schematic. The entire structure relies on a biological support network, the outer skin envelope and Cooper's ligaments, taut, load-bearing fibers that act like a suspension bridge, holding the glandular tissue against the chest wall. When breast volume increases, these ligaments and the skin stretch to accommodate the weight. But when that volume eventually decreases, the connective tissues do not snap back into their original position. They suffer from a mechanical phenomenon known as creep, resulting in a permanent structural elongation. Because this is an irreversible mechanical stretching of the tissue, no topical cream, specific diet, or exercise routine can reverse the process. The tissue has physically lengthened. The only way to restore the shape is to physically alter the architecture. When plastic surgeons evaluate a patient, they start with the geometry of the chest. This 3D wireframe highlights the inframammary fold, or IMF, the crease where the underside of the breast attaches to the chest wall. This acts as a natural equator and the baseline for all surgical interventions. Surgeons use the Regnal classification system to quantify the drop. By generating a measurement grid, they track the exact position of the nipple relative to that horizontal IMF line. This measurement separates the condition into 3 grades. Grade 1, where the nipple sits at the IMF line, Grade 2, where it sits below the IMF, and Grade 3, where the nipple points toward the floor. Identifying the exact grade of ptosis dictates the surgical approach. The severity of the drop tells the surgeon exactly what geometric shape they need to cut into the skin to reconstruct the breast. In Grade 1, or mild ptosis, the structural drop is relatively minor. The nipple has lost its youthful position, but rests at the IMF. To fix this, surgeons use the periareolar lift. They map a donut-shaped oval of skin around the areola. Stitching the wider outer edge to the inner edge with a purse string suture forces it to cinch inward, pushing the nipple up and narrowing the breast. Grade 2, or moderate ptosis, requires more aggressive intervention. Here, the nipple falls below the IMF, and the lower pole breast tissue begins to hang downward. In the vertical mastopexy, the geometric cut changes. The surgeon makes a circular incision around the areola and removes a vertical wedge below it. Closing this 2-dimensional gap forces the internal tissue upward, projecting the 3-dimensional volume outmount into a cone shape. Removing surface area from a curved object reduces the size of the container, leaving the volume nowhere to go. The act of removing skin becomes the mechanism for creating structural lift. Grade 3, or severe ptosis, represents a total structural collapse. The skin has stretched extensively, and the nipple sits far below the IMF, pointing downward. For severe ptosis, surgeons use the anchor mastopexy. Removing this sweeping anchor shape of lower col skin allows them to cross the remaining tissue over itself. This creates an internal suspensory sling, transposing the nipple higher on the chest wall. There is a crucial variable in this equation: internal volume. If the breast has suffered from a significant loss of internal tissue, tightening the skin envelope leaves the patient with a flat, empty cone. In an augmentation mastopexy approach, to correct volume loss alongside ptosis, the surgeon must simultaneously tighten the biological skin envelope while inserting a synthetic implant to restore the necessary mass to the breast cone. Severe cases require a dual architectural fix, reducing the size of the biological container while actively refilling its internal volume. Immediately after a vertical mastopexy, the breast looks geometrically unnatural. It sits high on the chest, looks overly full at the top, and appears flat at the bottom. This is an intentional phenomenon known as overcorrection. Surgeons build the architecture high to anticipate the immediate, inevitable pull of gravity on the newly positioned tissue. Over the next 6 to 12 months, the tightened skin gradually relaxes in a process called fluffing. In this simulation, the internal volume settles into the lower pole, stretching the skin just enough to round out the bottom of the breast. It is only after this lengthy settling period that the breast drops into its final self-supporting contour. The trade-off of a mastopexy is written on the skin. The patient trades permanent, visible, geometric scars in exchange for restored structural proportion. Adjusting these measurements is a calculated effort to manage the tension of the skin envelope against the weight of the gland. It shows that while biological aging is constant, the breast's position is a result of structural mechanics that can be recalibrated through geometry.